Improvement Foundation and the QI community bring you this month's QI webinar. Thank you for joining us. Hi everybody, welcome to QI Community webinar number 6, April the 8th, 2014, and this is part 2 of our masterclass on care planning. Welcome along, I'm Tony Lembke, I'm a GP in Austinville in the far north coast of New South Wales, and for this session we're joined again by our friend Ros Rolleston, a very experienced practice nurse and educator who works down the Shoalhaven and is based in Nowra. In our first masterclass, we looked at some of the systems and processes used in doing care planning, including using the item numbers appropriately. And Ros, in this masterclass, we're going to look at what actually happens when you sit down with the patient and do the care planning. And we might ask you, Ros, please, if you could let us know the learning objectives for this session.
Yes, so tonight we're just going to have a quick look at the PNIP, and we'll also have a look at the diabetes cycle of care. That's just a couple of things that were left over from last session, and then we're going to really look about patient-centred assessment, how we actually get in and do it, the nuts and bolts.
Great, thanks Ros. So the PNIP, now that came in 2012 and replaced some of the independent nurse item numbers. How does that affect the practice nurses in general practice?
So the PNIP has been a really interesting introduction, and as you say, Tony, it's only been since 2012, so 2 years. So it replaced all the other item numbers we used to use that sometimes dictated our practice and kept us to those item numbers rather than expanding our role to more suit the needs of the practice. So I think just to look at the funding side of it, it is $25,000 per 1,000 swappie, which is about the equivalent of one full-time GP, and that's for an RM working 12.6 hours a week. So it's capped at 5,000 swappie, $125,000, and that would need an RM working to the equivalent of about 1.6 full-time equivalents. So if we have enrolled nurses employed, then that's precisely half of that payment. I think it's also important to note, particularly for us from the rural areas, that there are rural and AMS loadings as well, between 15 and 50% on top. And important for those practices that are looking to develop and employ nurses, there is a one-off payment of $5,000 as well to help assist in getting your practice accredited so that you can be a part of the PNIP.
Okay, good. Thank you for that, Ros, and that clears that up a bit. The other question that came up after last time is the timing of MS rebates regarding SIP payments and their relationship with the chronic disease management item numbers.
Yeah, there were a couple of questions, Tony, and I think often in the practices we're getting pretty good at the diabetes cycle of care. We know that the diabetes cycle of care is $1 sign-on payment, $1 per swappie for the original sign-on. And then when the GP bills the diabetes cycle of care, then that's a $40 SIP payment to the GP. And once we actually get to 50% of our patients with diabetes in the practice who have had the diabetes cycle of care billed, then we can also get a $20 PIP payment to the practice. Important to note here that the diabetes cycle of care can be claimed at the same time that you claim your care plan reviews. The difference there is with the asthma cycle of care, it's a little bit different and not as well taken up. There's been misconceptions that you can't do an asthma cycle of care and a care plan, but this is not the fact. If a person does need that comprehensive team care environment, they certainly can have both. But Medicare considers the asthma cycle of care because it involves reviewing how the patient's going and a couple of appointments with the GP. They don't like this billed at the same time as the care plan review. They see that as a duplicate service, so they won't pay them on the same day. So the asthma cycle of care kind of gives us a 25 cents per swappy sign-on payment, but the SIP payment to the GP when the item number's billed is $100. So I think as nurses we often like to draw our GP's attention to that there's value for the patient as well as value for the practice to do that. We've got the mental health care plan there as well, just to remind everybody that in chronic disease management, mental health is a big component and we need to include that. If mental health is the primary illness, they may need a care plan as well, but people with chronic disease having a care plan, we need to assess whether or not we need to have the mental health care plan for these patients as well.
So you can have both mental health care plan that gives you makes you available, makes a better access scheme of seeing psychologists available, as well as being managed under the chronic disease management EPC items.
Absolutely, Tony, and we need to remember that, you know, depression, schizophrenia, these are all chronic illnesses. Our patients with primary mental health illnesses often can benefit greatly from having the physical side of things looked at as well as the referrals and the team care arrangement.
So there's a couple of questions come in, Ros. One is about the percentage of SIPs, of diabetes cycles of care that have to be completed to get the higher tiered rebate. That's recently been increased, I understand.
When I last looked at this, Tony, it was 50% of your patients with diabetes. Remembering that the way your number is by the HbA1cs done in the practice. So if your GPs have been using the HbA1c as a diagnostic tool and you have some people who haven't indeed got diabetes, they will reduce the percentage of patients that you have billed. But to the best of my knowledge, it's at 50%.
Now, Ros, just to review what we talked about last time, some of the processes in practices for doing the chronic disease management item numbers.
Yes, Tony. So we just wanted to quickly just recap where we were at last time. We talked about chronic disease management, it's important that it's team-based collaborative care, that we have a process in place by every team member knows what their role is going to be, who's going to identify the patients. We agree on what we're going to do during the care planning appointments. We need to all be happy about our templates and who's organising our recalls.
Okay, and that's what we discussed in our masterclass number 1. We also talked about some of these issues last time.
Yeah, just to recap again, that we talked about longer appointments for care planning for nurses to be undertake comprehensive assessment. We also chatted about how the nurses get a lot of information by actually going through the whole file and looking at all the information that's there. And what we need to do now is to really set the scene with active listening. We need to be attentive. We need to watch our body language. What messages are we giving across? And certainly watch the patient's body language. You know, they're squirming in the chair or feeling a bit insecure there. It might give you a notion that you might need to probe a little bit more here. We always use open-ended questions in our care planning, and we always include the patient in the decisions. Really important that the patient feels that they're a part of this process.
So the first thing you do when you sit down with a patient in a care planning consultation is to undergo the process that you've termed patient-centred assessment.
Yes, Tony, patient-centred assessment. And my slides are actually loading a bit slower, everyone, but We've got the picture here, have we?
We've got the picture, and then now we're going to talk about the things that you do in the
Lovely.
beginning.
Yeah. So that's just the picture that's telling us, showing some of the area that we live in down here, why it's so beautiful. It's Cathedral Rocks at Kiama.
Yeah, it is lovely. So the next slide's about the things you do, the body mass index, blood pressure, pathology and medications.
Yeah, so in the very beginning, this part of our assessment here is really where we set the tone of the whole appointment. We're going to gather a lot of information here in these next few minutes and see what's important for the patient and set the scene of including them and making it patient-centred. So I always put the scales between the door and the chair, so there's no two ways about we're going to use those. But here it is really important to be careful of how you respond to the number on the scales. So if you were to say to somebody you've put weight on, or that's 120 kilos, you're setting this up in a negative kind of tone. So I always like to ask patients here, is your weight stable? Before I say anything else about it, is your weight stable? And you can see that really changes the conversation that's going to come around weight. So once I sit them down in the chair and I put the blood pressure cuff on, I like to do, when I do my full care plan, I do a pulse oximetry and a blood glucose on everybody as well. Remember to actually feel the pulse. You know, I like our electronic equipment here because you can check the blood pressure a few times. Very wise GP that I worked with once told me that, or taught me, that it was actually the third blood pressure that you get that's generally the right one. Pretty interesting if you actually have a bit of a trial, the difference between the first and the third. And then what I do here is I turn the screen to the patient. I open up the pathology and I start going through all of their pathology with them. Because I've already been through the file before I've brought the patient in, I know what are the issues here, I know what we need to draw attention to, and generally the patients will see red and say, you know, the doctor told me everything was fine. And this is where, as nurses, we come on board and we can explain to the patient that, yes, that's correct, because the doctor has actually looked at you, the individual patient, your medications, your medical history, and how you're going. Whereas the pathologist has to say normal or abnormal. So we've brought the GP into the room, even though most of this consult will be with the nurse. I then open up, while they're still looking at the screen, and I open up their medication list, and here we're looking for concurrence. Do they know what they're taking? Do they know why they're taking it? And are they actually taking their medication? It's really interesting here to see what patients know about their medications. Often a bit of time needs to be spent here, and we can bring in the EGFR and the cholesterol into the discussion about the medications, why they're important, why the doctor has this regime happening.
So it would be really good, wouldn't it, if the medication list that we had on a computer had any similarity with what the patient actually takes.
Oh, Tony, I just love it, yes.
I like the way you're always positive in your reinforcement to the patients in their behaviours. Questions come up about, Ros, about waist measurement. Is that something you do routinely?
I reserve the waist for when I do health assessments. It's not a part of my routine for care planning, but I know that a lot of people do it. Once we look at the guidelines for chronic disease management, the waist measurement isn't in the language anymore. It's really used as a tool, as an indicator for illness. But certainly, you know, if it's a part of your routine, I love it when all the boxes are filled out in the clinical section.
All right. Now, the next thing you do, Ros, in your practice is ask the patients to rate their health on a scale of 1 to 10.
Really important now. This is, you know, we're probably already 20 minutes into this assessment, but we really need to bring the focus with the patient. So how do you feel your health is on a scale of 1 to 10? You're going to get so much information from asking this. And the next question, what is your main health concern? The information that you get here is going to set you up for a lot of your other work that you'll be doing around goal setting. Patient feels this is really important. I'm the person that's the centre of this appointment, and the nurse is asking me how I feel. Then I always talk with them and assess, how long have they had the illnesses that they have and how much knowledge do they have about their illnesses. In this section, this is where we're looking for those referrals for maybe we might need to see the diabetes educator or the heart failure nurse. Get a lot of information from this section too.
So, Ros, we also ask patients to rate their score on a health on a scale of 1 to 10. I find it fascinating. If somebody says they're a 9 out of 10, then you know that there's not a great deal of the things you need to change for that patient. And sometimes, remarkably, patients with terrible arthritis will still rate their health as 9 out of 10. If someone rates their score as 4 or 5 out of 10, you know there's some work to do, and you can ask them, what would it take for you to be an 8 or a 9 out of 10? And then we can really focus our interventions on things that'll make a difference for them. And similarly, by following it over time, you can see whether somebody's improving or getting worse from their own perception. I find it really useful.
Absolutely. Yes, I agree, Tony. And it's just these small questions that we ask that we actually gain so much information from.
Now, Rosa, just to clarify, when you do check the patient's medication list and for concurrence, and you find there's a difference between what they're taking and what's in the computer system locally, or if they've got a health problem that's not listed, do you add it yourself to the record, or do you bring that to the doctor's attention? How do you handle that?
It depends on the practice, but often nurses don't have access to the medication list, so they might not be able to make adjustments there. Where the nurse can make the adjustment is where on the medication list it goes into the care plan template. So we can fix that up and add the little aspirin or take out those that aren't being used, and then definitely draw it to the GP's attention. But I just want to go back to the first session that we talked about with care planning, and we talked about an autofill. And the autofill is really the outcome of the process that the practice has gained in their care planning. A part of that autofill was where the GP fills it in and they tick yes that they've updated the medication list and the past history. Really important that we get that communication across.
So some practices I know are giving the patients in their waiting room the printout of their understanding of their past history and current medication list, and while the patient's waiting, giving them a pen and asking them to adjust that if it's incorrect. That can be a helpful approach some practices use.
Yeah, absolutely. And this is what's wonderful about webinars and that, where we get to hear about what each other is doing and what a great job we do.
So the next thing in your patient-centered assessment is talking about the patient's nutrition.
Yes, so nutrition is really, really important, and I always ask the patient first to assess their knowledge is your diet healthy? And I type all of this information as we're going. I'm typing it into my template, which we'll have a little bit of a look at towards the end. But is your diet healthy? Often they feel that their diet is healthy, but when you actually ask the next lot of questions, you can find that it's not. So it's really important that we don't just stop superficially on nutrition. We need to find out what it is that they're eating day by day. So I always ask, what do you have for breakfast, lunch, dinner and snacks? And I type all of this onto the care plan. How many serves of fruit and vegetables? I bring that back around and help the patient assess how many serves they're having, what kind of meats, what kind of bread and dairy that they're having. Are they drinking any water at all? Do they add salt to their cooking or at the table? How many takeaway meals do they have? We need to get all of this information so that we can assess correctly what's happening here and whether or not this patient might benefit from a dietitian.
Rightio. So, Ross, you've talked about the calories in, and the next thing you asked them about is the calories going out. it occurs to me that the competencies required of nurses doing care planning, they need to have skills of the GP, of the dietitians, of behaviouralists, of psychologists, of exercise physiologists. It's incredible.
Tony, I just love it that you say that and recognise the comprehensiveness of the skill base that a nurse needs to effectively do patient-centred care planning. I think in the first year that I did care planning, I spent my time learning all about the MBS, learning about all of the RACGP guidelines. When I made it into my second year, I then really spent time honing in on my skills, my time management skills, and looked at all of those complex illnesses like, antiphospholipid and stuff that I'd never ever heard of before. And then when I got to my third year of care planning, it was all about the patient. And then there was a change in my role. There was a change in the way that the patients viewed care planning, and there was a change in the way that the GPs viewed care planning. So it took me 3 years of working before I could really bring this around to patient-centred care. And I think it's important that we think about that. New nurses into general practice will struggle with care planning in the first instance, and we need to support them.
Yes, it's certainly a most valuable set of skills, and it takes time to acquire. So talking to patients about their calories out, their activities.
Calories out. So you can see here that the slide is activities. It's not exercise, because exercise brings negative connotation into the consult. So we talk about activities, staying positive. What activities do you enjoy? How active is your lifestyle? What are the barriers to the activities that you like to do and you might not be able to do? And are there mobility issues here? Really important. And once we've gone through all of this and talked with the patient and congratulated them on every little tiny thing that they're doing, that's when we can bring in, is there specific exercise that you do? Or are you able to maybe try a bit of exercise a few days a week? So this assessment here is also saying, do we need to see physiotherapists? Do we maybe need to see the exercise physiologist? So you can see the whole way along we're setting the scene about what we're going to do at the end with all our referrals.
Okay. And having talked about that, you move on to their sense of well-being and mental health.
Really important again, as we said at the beginning of the webinar, mental health is a large component of chronic disease management, and we really need to look here, is there an unmet need? So it's about, I'm not doing a K10 or a DAS or anything at this stage. It's really about trying to identify if there are any worrying signs. So I always like to ask patients, what's your daily routine? Because if they tell me that they get out of bed at 11 o'clock or 12 o'clock, I already know that potentially we might have something happening here, that they don't want to get out of bed first thing in the morning. How many hours of sleep do you normally get? Is it difficult to get to sleep? Do you wake up in the middle of the night or early mornings and can't get back to sleep? These are signs of anxiety. Do you ever feel sad or alone? And most people at some time feel sad or alone. So we're listening here about how complex this is for them and what it is that they do to overcome that. So do they have resilience, or are we really sitting here with depression? Same again about worries and concerns. We all have them, but we're looking to see how they manage these worries and concerns, or is this anxiety developing? I always talk in the mental health and wellbeing area, talk about smoking and alcohol. Really important that we have the discussion, even if they're resistant and they're not ready to move on, but we have the discussion is important. And I always ask about other substances. Don't be shy to ask about other substances. Some people, you might need to prompt them a bit and say things like, cannabis or amphetamines, and it might surprise you that there is a reasonable proportion of patients that are using other substances. Reason this is important is often that's a sign of other things happening as well, whether or not that's anxiety or depression. Always every opportunity that you can to talk with the patient and ask about, have you ever had thoughts of self-harm, or have you ever thought about killing yourself or suicide? If I identify through this consult that there is a mental health issue here that may be undiagnosed, I'm not going to address it all at the time. I'm not going to have the time to do that. So I will ask the patient if it's okay if we come back, because I think it's really important that we have a consultation where we get to focus on this. And generally at that stage they're pretty happy to come back and have a look at it, because you've had such a good conversation, you've kept it in the positive, you've identified a few issues that they've told you.
So we know
And they're
that
happy then to sign off.
we know that depression is a common comorbidity with many other chronic diseases. But Ros, no one on the north coast of New South Wales uses other substances. Unheard of.
All those hippies.
They've all gone straight now. We talked a bit about medications, Ros. You also asked about complementary therapies and decide whether the patient would benefit from a home medication review.
Yeah, so we have already done the majority of this assessment back there in the beginning, and it's just about bringing it all together here. Complementary therapies, side effects, and really important question, do they have a regular pharmacist? Because I think it's really valuable for the patient to see the same pharmacist every month when they get their scripts. And I want to put the pharmacist on their team care arrangement. And this is where the opportunity comes for you to talk about the HMR. Often they're a hard sell, the HMR, but this is where we get to remind the patient that, you know, the pharmacist will come into the home and go over everything, empty out all the boxes, talk with them about everything, and then actually provide some good feedback to the patient and back to the GP as well, to make sure that we're on the best regime. So I try not to say things about, you know, do we have medications that, you know, might not be good together. Stay away from the negative, and do we have the best regime for you at this time?
Patients spend more time with pharmacists or have more encounters with pharmacists than any other health provider in the system. And I think you're right. I think we underutilize and under-acknowledge their role in chronic disease management. Immunisations
Yeah, absolutely.
And then Ros, you check on their immunisation status.
Yes, certainly. It's something that we do wonderfully as nurses as well. And often, you know, in these months of the year, we'll be doing the seasonal flu vax, but it's also important to remember the pneumococcal. We had a few years back where there were a few reactions, and we all got a bit confused about who has 1 or 2 doses or 3 doses. And anybody with those chronic illnesses, cardiovascular, renal, people who are consuming regular excess alcohol, renal patients, pulmonary patients, diabetes, all of these people need to have their second and third dose, if they're still with us, of pneumococcal. This is all recommended in our handbook there for us to see, but sometimes we have to remember that. Make sure you've got it in your recalls as well. Hep B is another one that recently changed in New South Wales a couple of years ago, and it's now free to most adults as well. So it's another important one to drive home here when we've got the time to look at the whole patient and all of their immunisation needs. Remembering if you've got patients that are renal patients, their EGFR is heading around the 30 mark, then it's time to actually give them their Hep B vaccinations as well, in preparation for potential future dialysis. Important to remember here as well that it is a special renal dose. It's a double dose of the Hep B. And then we always want to think about the DTPA and the MMR. We know that we've had measles in Australia in the last 12, 18 months, and everybody born after 1966 can have 2 free MMRs as well.
Okie doke. Now, Ros, you've gone through how you assess all of your patients as they come through in a patient-centered way. Now, there are some specific conditions that patients may have or comorbidities that they may have that require some specific further assessments. But first, you've got to tell us where this beautiful waterfall is.
Isn't it beautiful? This is in the Minamurra rainforest up in the highlands from the Illawarra, and this is similar to what our weather's been like lately. This is after there've been some significant rain. Isn't it just beautiful?
Yeah, wonderful. So, cardiovascular risk profile you would do on most patients, I suspect.
Absolutely. And what we're doing with these next few slides is we're bringing the medical guidelines in without having to have them all listed down the side and everything, but we're going to go through this again, being very specific and informing the patient that a part of this assessment is to look at their heart health. So I go back through the cholesterols, the triglycerides, do we have fatty liver here? Are they on a statin, or maybe is it time for them to maybe start a statin? If they're not on a statin, then we can do the cardiovascular risk assessment. And I also just bring back into my mind what was their pulse and blood pressure and blood glucose. Bring it all together here. I prompt myself on whether or not there's an indication for this patient to have an ECG. Often I'm not going to have time to do that ECG here today. If there's a treatment room nurse in the larger practices, sometimes they can pop out there. But I like to reserve this for a bit down the track when I'm going to do this routinely, and it's going to be at a time that I'm going to be able to spend a few minutes talking to them about their goals and where they're at as well, and get their ECG done. I come out of intensive care, so I like to have an ECG on file for everyone with a chronic illness, I have to say.
Rightio. So in wave 10 of the collaboratives, we're talking a lot about chronic kidney disease, and we've ascertained that it's very underdiagnosed in most of our patients. That's something you look at when you're doing your care plan.
Absolutely. It is so important to take a moment to stop and think about the kidneys. So what is the EGFR here? And if the EGFR is 60 or below, then we need to think about putting it up into the diagnosis, the stage of renal failure that this patient has, bring it to our attention. We need to make sure that we've been doing the microalbuminuria, whether or not they're ACR is on board, how their UECs are going, and their potassium's important to keep a really good eye on. Are they on an ACE or an ARB, something that's going to be really good for their kidney function? Are they taking non-steroidals? Another thing that's really damaging to the kidney, and again, I just reflect back on the blood pressure and the blood glucose according with the EGFR here. So it's really about focusing particularly on the kidneys at the time. Sometimes you might have a patient that's been a bit resistant to having antihypertensives, or even maybe changing them from the older to the newer ones, and this is the opportunity here to talk about all of this and help them actually see the great benefit there is with ACEs and ARBs.
Thanks, Ros. And these are some of the other clinical aspects you look at, particularly with diabetic patients, but also with some other patients as well.
Yeah, absolutely. This is all the remainder of the assessment and what we need to know for our cycles of care and our best practice. So we need to be talking about vision. Have they seen an optometrist recently to have their eyes checked? You know, how are their feet going? How are their pulses? Do they have any ulcers? Do they need to see the podiatrist here? This is a really important one. And again, then I just reflect on what the HbA1c is, the EGFR and the blood pressure, just to spend that moment in my own mind thinking about, have I covered all of these bases?
Okay, well, thanks, Ros. Now we move on to some further investigations that you like to check that the patients had, whether sometimes whether they've been missed or whether they're appropriate for this particular individual.
Yeah, absolutely, because that's one of the roles that we're doing, supporting the general practitioner when we're doing the care plans. And occasionally the blood tests haven't been attended, or maybe some have and not the rest. So we often need to look at the full blood count to see the CRP, especially with our arthritis. Sodium's a really important one to keep an eye on as well, especially if they're on antidepressants. And the B12 is another good one to have a look at, especially with our diabetics that are on metformin.
Yes, and we might do another webinar on vitamin D and whether it's actually worthwhile or not. We had a lady come in today with a sodium of 115 just out of the blue, so there you
Wow.
go.
Yeah, there you go. All those little things that we've learned across the time, they're still really important.
Now, Ros, is this the mighty Shoalhaven?
This is actually Lake Illawarra. It's beautiful, beautiful. Next time we will have a picture of the Shoalhaven River for sure. But I just really like this. I think it's great about goal setting, looking off into the future, achieving our goals. Beautiful vision.
It doesn't look like what it would have looked like tonight by the sound of things.
No.
So we've talked about SMART goals in the past, traditional SMART goals.
Yeah, I think SMART goals is something that most of us are familiar with. They've kind of been a framework for a lot of our work in the past, and we've always known traditional SMART goals: specific, measurable, achievable, realistic, and time frame. If you do this, then you'll be very smart. Over recent years, the psychologists have adapted these and developed them more into a patient-centered focus. And it's now about small goals, one step at a time. Not great big goals of lose 30 kilos, but 1 or 2 kilos at a time. And that these goals are authentic. They're authentic to the patient. They mean something to the patient. This is what the patient wants to do. Psychologists really push hard that we review our goal preparation and how we're getting there every night. Just spend 5 minutes just sitting and reflecting. What did I do to help achieve my goal? What were the barriers today? And of course, we stick with the time frame because that helps us keep progressing.
So our collaborative practices will be familiar with goals. It sounds like we're doing PDSA cycles on our patients with small incremental steps, looking for measures, looking for change ideas that may lead to an improvement, all within a limited time frame. So our goals become little PDSAs. I like that, Ros. That's nice.
Yes, very nice.
The the stages of change. Do you find them a useful framework as well?
Yeah, again, it's another framework that we're kind of used to having around, and we have it in the back of our mind. Is this patient really at pre-contemplation where they might just be, one day I want to give up smoking, or are they actually trying to prepare themselves to get here? You can pick this up from the language that they use in all of the conversation that you've had leading up to here. Are they at contemplation stage where this is where we really need to get some information to them, and then how can we get them over to the next step of action? Once we've got to action, then it's really that hard slog of keeping people, maintaining them along, and using reflection like in the contemporary goals is a good way of doing that.
Okay. Now, Ros, motivational interviewing is a subject that could again be a subject of a series of webinars in itself. Is this a skill that you recommend our care planning nurses acquire?
Absolutely, I think it's extremely important. Everybody that's working along in care plans and in health assessments to help a patient actually move through the stages and get somewhere. Motivational interviewing is really good. Sometimes as nurses we feel that we have all of these skills, we've developed them across the years, but I strongly recommend that you go and do a course in motivational interviewing. You will learn so much about the techniques and the theory behind it and how to best help your patients using it. So often Medicare Locals organise this, so that's something that you might like to think about. But what it's all about is about helping the patient to prioritise what is the main health issue. And we got all of these answers back in the beginning, where we got them to rate their health and tell us their main concern. In rating their health, they've also told us how important, but again here, we like to say, on a scale of 1 to 10, how important is it here that you actually achieve this goal? Same again with readiness. Are they ready? It might be really important. They might have the priority, but things are not working out for them at home at the moment, and they're not ready just yet to do this. No sense in pushing this person further. We just need to know where they're at here. And again, their confidence. So how confident are you that you can achieve this? Really important to rate this on a 1 to 10 as well. Then you get to look back and have a think about, how important was it on the scale of 1 to 10? How confident are they that they can achieve it? Often there's big gaps in the numbers here. And this helps us to be able to give people tools, the tools they need to help them, whether or not that's the quit line, whether or not that's the dietitian, whether or not that's some information sheets or some websites. But what tools can we give the patient to help them here?
Yeah, so we often ask about importance on a scale of 1 to 10 and confidence on a scale of 1 to 10. And we notice, Ros, when we ask women how important is it for them to lose weight, they rate that very high, 9 out of 10. And how confident are they that they can do it? Often 2 or 3 out of 10. But however, if you ask
Yes.
men how important it's for you to lose weight, or 3, how confident? Oh, 9 out of 10. If I wanted to, I could. So
Yes.
it's an interesting difference between the sexes there.
It is.
Healthchangeaustralia.com. I don't know that site, Ros. Is that a tell us about that?
It's just. It's been well established, Health Change Australia, for some years now, and it's just a good website to kick you off around your motivational interviewing. Great lot of resources there to have a look at.
All right. So in summary then, with our goal setting, Ros, you like to keep them very simple and a maximum of 3.
Maximum of 3. Can't overload the patient. He spent so much time keeping this patient focused. If you then turn around and give them 5, 6, 7 goals, then it's just not going to work. Remembering that it is the goals that they're coming up with and what they're agreeing to. Otherwise, we're not going to be able to move them through even with our motivational interviewing. So very simple goals. By far the most important one when I'm actually doing the 72123 is for the patient to arrange their appointments, to arrange the appointment with the specialist or the dietitian or whoever it is that they need to see. They often just want that simple thing of being able to walk the dog. What are the tools that we need to get to this person to help them walk the dog? Maybe it's lose a couple of kilos, 5 kilos. These are great goals to have because you can see in the future that you might actually get there. And a lot of our older population really just want to get back to playing a little bit of golf.
All right. Now, Ros, I'm just interested in the mechanics of how you do all this. That's a very comprehensive assessment, both of their general condition and some of their specific conditions. Are you typing into a template while you're talking to the patient, and that becomes how do you do that?
Yes, that's it. It's typing. I always tell the patient at the beginning that I do have a lot of typing to do as we go, but all the information that I'm gathering from the patient, I'm typing it into the template. That's what the patient is going to get to take home as well. They're going to be able to see everything that we've talked about. So sometimes people say to me, how can you type and be patient-centered and patient-focused? But you've got to be really clever here with your time. Sometimes you can fill out parts of the template and I'm scrolling up and down all the time and stuff. And when the important stuff is there, you stop typing, turn and make the eye contact with the patient and talk to them. It's a real skill to type and listen attentively at the same time, but by golly, they'll certainly know if you've dropped it there and you've asked them the same question twice. So be careful here as you go, but definitely it's very complex, and I think that's why I say it really took me 3 years, Tony, before I felt that I was successfully at this level.
So this is a template you use. This is best practice format. Ros, is that correct?
Yeah, so it's a little bit kind of hard to appreciate it as much as what we do, when it's loaded up as a template. But my first page is all the demographics and medication list and past history, and this is my assessment page. And you can see that these are all the realms of assessment that we've talked about. Everything that we've gone through is here on this template. When I first started off with my templates, I used to have in this far left-hand column all of my prompts for the questions that I needed to ask. Now it's just become flow, but this is a great way to start. And you can see the far right column for me, this is my review assessment. So what I do for a review is I load up my template, I come into this section and I go through and I have a look at where they've been going and achieving their goals, what blood pressure. So what I essentially do with this review column is turn it into a to-do list for the patient. So I'll prompt them here that they need to see the dietitian. I'll do their blood pressure. When I do the ECG, I'll write in the column that it's attended and that it's sinus rhythm or it's AF with a left bundle branch block, whatever it is. So I give them progress and prompt them of the things that they're going to be doing before they come back next time.
And so you also have another page in your care plan, which is where you document all the members of a patient's care team.
Yes. So in between these two pages, I actually load up all of the assessments and crop the pathology and crop that down. So all the recent blood test results are going to go into this care plan. And then this is where I load up here all the team members, all the contact details of everybody, what the treatments that are required, and now here what are the patient-centred goals. Remembering that we don't have to fill every single box up here and that it is the patient-centred goals that we're looking for. And then at the bottom of this page, this is where the GP gets their opportunity to sign in. And I think, it's when we get to here, we've got all of this filled out, this is where, we're probably in the last 10 minutes of this consult. And it's where I need to really start pacing the GP here. If I'm going to get the GP to come into the room, I've got to actually synchronise this timing really well, what's happening before they get their next patient maybe. But now it's all of the referrals that you have to write in this last few minutes that you've got the patient with you. And I generally just have a little bit of chit chat and ask them, is there anything else that they wanted to talk about while I get all of these referrals done and everything ready for the GP to sign off.
So as we discussed in the last webinar, sometimes practices will have a procedure where the patient will see you and then have a booked appointment with their usual GP, and in other practices, Ros, you'll be grabbing the GP in between their normal patients to come in and review the care plan.
Yes, that's my favourite, is for the GP to come in and we can have the handover. While the GP's signing all the paperwork, I can tell them what are the main key points that we've talked about, what are the main issues that we've prioritised out of this appointment, and steer the GP in the direction of what they need to be chatting with the patient about. And while the GP's chatting, this is when I'm putting all the paperwork into the file, so it's all nice and neat and complete. But it's not always possible. Doesn't always work in every practice, and it's as long as you're getting some form of handover, whether you're using that as the F8 messages or a post-it note, some form of handover to the GP is really important.
So two things I want to clarify. One is where it says they're required treatments and services if they're seeing a podiatrist. How much detail do you go into about what the podiatrist is going to do?
I don't go into a lot of detail here. I'll generally just write podiatrist, physiotherapist, dietitian, because it's really about helping the patient realise what these team members are all about. I actually go into a bit more detail with the facts that I send over, and I'll say, this patient has these particular illnesses and this is the treatment that I'd like you to look at. So not a lot of information here, remembering this is the patient's care plan.
So that's the other thing I wanted to clarify. So you print this out with their pathology results and their medication list and their health summary, and it goes in the blue folder for the patient to take away with them.
Absolutely. In the blue folder, it's all there, all the information ready for them. It becomes their care plan, and it's got everything that we've talked about. So even when they read it, they can remember back to those conversations. It's their care plan, and they feel very happy that they've got the care plan. So what I always like to do is I always thank the patient for coming, make a point of doing that. And as I hand over the folder, I congratulate them on becoming an active participant in their healthcare. Really important conversation to have here, and you can see patients light up and they thank you and they say it was a wonderful appointment and they'd love to see you again. And that's when I say, have a read of your care plan when you go home and give me a call if you have any questions.
And that's a great opportunity, Ros, ideally to set the date for the review for the care plan in the 3 months or the 6 months or whatever is the most appropriate time period.
Yes, definitely. It's we've gone to do a lot of hard work here in this appointment, and if we fail to review the care plan, we're failing the patient. It is no longer patient-centred care. So it's really important to update your reminders and your recalls right here and now. We need to do this. We need to tell the patient why it's important that we see them on a regular basis.
So, Ros, I guess here with the Pacific, we share this in common. This would be the Pacific Ocean with the sun rising.
Absolutely beautiful, isn't it? We do share it in common. This is again from the Illawarra, Port Kembla actually, which is a very industrialised area, but it's just a beautiful photo. And I think it reminds me, of every day when we go to work. There's always something that we can do a little bit better, but we need to pat ourselves on the back because we're doing a really good job.
So I think we're going to finish with the framework that we've developed in our practice, which we call the 7CCs, the 7 care components of all our chronic conditions consultations. This is what we try and do in our practice with each, both care planning consultation and with the review of the care planning at the 3 and 6 months intervals. And I've put these at that web address is the article that this little bit's based on. I'm very happy to see that it overlaps enormously with the components of Ros's care planning, and that's probably because I've stolen shamelessly from her over the years. And but the framework we use is divided up into these 7 components. And the first one is the comprehensive core, the changes and the concerns. So how are you going on a scale of 1 to 10? What's changed since we last saw you? What are you really worried about? And then he's sort of, as Ros said, if we're having a patient-centered approach and we ignore the patient's concerns, then we haven't done them a real service. So number 1, we start off with their comprehensive core measures and their changes and concerns. Step 2 that we work through is looking at the care team and communications, and I think this is extremely important to document all the health providers that a patient is seeing, and that includes other consultants and other clinicians, who they're seeing for their chompers and what chemists they're seeing. And then the communications that have come in from each of those. We've got a letter from your cardiologist, he said this. We've got a letter from your physio who said this. These pathology results and other communications that have arrived since we last saw them. I think it's important at the beginning of the consultation to review what's happened to the patient since you last saw them, so that they know that the healthcare team is all on the same page. Step 3 is the challenges that a patient has, and Ros referred to them: their calories in, their calories out, how they're going with their ciggies, their coldies and their shardies. What cool things are they doing? Do they find fun things to do? And that's to do with their mental health and well-being, and how are they sleeping. So they're their core challenges and goals. And then we like to run through all the conditions that a patients have. So we'll run through, now you've got diabetes. There's some specific goals in relation to that: HbA1c, their blood pressure. You've got a history of peripheral vascular disease. We note that you do for carotid Doppler studies. You've got a history of renal disease. And we run through each of their conditions and any specific goals related to those conditions. And in that sense, their current problem list in the medication record needs to be quite up to date so that we can hit each of their conditions without skipping any preventative activities or activities that are meant to be part of that. The next one, number 5 of the 7, is concurrence, and you referred to that, Ros. That's the charts, the medication charts. How concurrent are they? And also their communications. Yep. So is the health summary accurate, and is that ready to be shared to the PCHR if we're involved in that? And then our communications back to the other members of the care team once we've updated their progress towards their goals and targets, the medication list is accurate, and the current problem list is accurate. What communications do we have to send out with that patient so that each member of the healthcare team has information they need to do the best job that they can when they're looking after them? 6 in our framework is about their confidence and the chores. Do they know what they're meant to be doing in the next 3 months before we're seeing them again? Do they have all the tools that they need? Do they have the pathology forms? Do they have their repeat prescriptions? Do they have their referral letters? And are they confident they can meet all the things that you're asking them to do or suggesting they do in the next 3 months? And we would rate their confidence also on a scale of 1 to 10. We really don't want them having to come back and pick things up, having gone through this process. If they remain well, we don't want to see them again for 3 months. We want them to be confident they've got everything that they need. And the 7th one is the calendar checkup and charging. When are we going to review them again? Have they had their preventative health checkup, which we try and do their annual check once a year to check their preventative activities? And have we charged them appropriately? Are we up to date with our 721, 723s, 732s, HMRs and SIPs? And the doctors always need the help of a good care manager nurse to work out what they're meant to charge. If we're going to have Ros's time for an hour with the patient and our time running through this rather long list of preventative activities, then we need to be able to keep that going in a sustainable way by charging for it. So that's our 7cc framework. In summary, we identify that by the end of the consultation, and we do this, our care plan nurse will do half and we'll do half. By the end of it, all their concerns have been identified and they have plans to deal with them either then on that occasion or at some future appointment. We've identified the care team and checked their communications. We've addressed their core challenges and goals. We've checked the concurrence of their medications and their shared health summaries. They're confident they've got everything they need before the next 3 months. We've scheduled their checkup on the calendar and charge them appropriately. So that's the framework that we use, the 7ccs, the 7 care components. It used to be called the 10ccs, Ros, because I liked the band and each of these care components had a song. These are the 10ccs, the things we do for love, and had a song attached. But I told the registrars and they'd never heard of the band 10cc, and all my great illusions were lost on them. So I've shortened down.
It didn't work for them.
Didn't work for them.
But look, Tony, I think it's just brilliant, isn't it, to have the actual framework in the background. This is what's driving your care planning process. And it's really important, I think, to go and have a look at the Practice Improvement website where the 7Cs framework is available, and, you know, put that as one of your bookmarks so that you can go back to it at different times to help keep the process alive.
So, Ros, we're going to finish there. There are a lot of templates that practices that are using that are very valuable, that they've spent a long time developing. We're going to set up a repository on the QR community site for the best templates. We may even have a prize of a trip to the beautiful Shoalhaven area to have some nice cheese for those practices that have the best templates. Ros, you can be the judge. But
oh, that would be lovely.
So if you want to, Alison put her email address up, I noticed. Practices that good templates could send them in, and between us we can, the templates help develop a framework for, I think, doing comprehensive chronic care consultations. And if you've developed a good one, we'd be really, really happy to see that. If you'd be happy to share it generously, we'll all steal it shamelessly.
I'd just like to add there, Tony, sorry, before we go on the template, that template that, you know, that is available for anybody to get from the Improvement Foundation, the one that I've shown tonight and looked at, that is the one template that I use for everybody. Right. Everybody. So I don't have disease-specific templates, because what I found is every patient deserves to have that comprehensive assessment.
Yes, I think that's right. In the beginning of the collaborative process, we start on diabetes or heart disease, doing nurse-led clinics on those specific diseases. But we've discovered, as you've discovered, Ros, that the management of chronic conditions is generic, that the skills required in assessments and in motivational reviewing and in goal setting are common across all the comorbidities. And therefore, most practices now run chronic condition work clinics rather than specific disease clinics. And I think that's
Yes.
reflected in the fact that you've now down to one template instead of billions of them.
Yes.
Look, Ros, on
And you
behalf...
don't want to become a slave to the templates either, that you have to go and, change all these different templates every time the guidelines change. One suits me.
Good on you, Ros. Look, on behalf of all our participants in the QI community and those of this webinar and the last one, I'd like to thank you very much for the thinking you've put into this and allowing us to benefit from all the experience and knowledge and skills you've acquired. I think they've been really valuable to me, and I'm sure the feedback I've had is that other people have found it very valuable too. We'll have to get you back sometime, Ros.
Thank you.
So thank you very much. And now, Ros, the next webinar is in May. The day may change and the time may change, and that'll be talking with the Heart Foundation on managing cardiovascular risk factors in our community. The QI community website platform is a space that we can go to share some of these ideas. The resources that were mentioned tonight will be available there, as will a recording of this webinar. Now, as always, we'd like you to complete the evaluation that will pop up when we close this meeting so that we can improve what we're doing for future times. So thanks, Ros. Thank you very much. Thank you, everybody, for joining us, and we'll see you in May.
Thanks, Ros. Thanks, Tony.
And the QI community
Bye now.
present this month's QI webinar. Thanks very much for joining us.